All right, so today we talk about interstitial disease. And when you're discussing interstitial disease, it's important to discuss the distribution. From the chest radiograph, is it upper lung distribution or is it lower lung? And that's where you usually start. But today we're going to talk mostly about lower lung interstitial diseases, specifically the idiopathic interstitial pneumonias. The most important thing whenever you're discussing interstitial disease is the clinical history. So I would advise that you always look in the chart to see what history you can get. And as we proceed, you'll see why that can be important in terms of formulating your differential diagnosis. So here's a patient who's short of breath, and we can see that there are increased interstitial markings here in the lower lung. So there's the chest radiograph. Here's the CT scan. So what do we think is going on here? Well, what are the findings on the CAT scan? So where's this consolidation?
Middle lobe.
Yeah, so you have some right middle lobe consolidation and volume loss and atelectasis. Anything else?
The tree and bud opacities.
Yeah, so you have some tree and bud opacities. What about the bronchial walls? They're thickened. So what do we think is going on here? Well, is this interstitial lung disease?
No.
No, what do we think this is? Aspiration. Yeah. So this is airway disease. So this is from chronic aspiration. You have tree and bud opacities, parabronchial thickening, consolidation with some atelectasis in the right middle lobe. But that can also look like interstitial disease on the chest radiograph. So that's why bronchiectasis is also in the differential when you look at the list of things that can look like interstitial disease on the chest radiograph. Okay? So, bronchiectasis, irreversible dilatation, infection is the most common pathway when we get bronchiectasis, but on the chest radiograph, this can look like interstitial disease. So here you have these cystic opacities here, just parabronchial thickening, and this turns out to be bronchiectasis. Of course, we can get this with chronic aspiration. You can get it from anything that increases susceptibility to recurrent infections also. So this person is short of breath, and they have kind of a reticular nodular pattern bilaterally in the lungs, and the CT looks like this. So what do we think here?
You have interlobar septal thickening.
Yeah, so we have interlobular septal thickening, right? So what do we think the cause might be?
Could it be malignant because there's like a chemo port on the previous?
Yeah, so one clue that you have was that there was a chemo port here, right? And secondly, do you think this is smooth or nodular, this thickening of interlobular septae?
Nodular.
Yeah, it's somewhat nodular. So what's your diagnosis here then?
Lymphatic.
Yeah, so this is an example of lymphangitic carcinomatosis. So this can also look like interstitial disease on a chest radiograph to give you that, in this case, a reticular nodular pattern, but it can look like an interstitial pattern also. So we've covered lymphangitic carcinomatosis before. This is when we have permeation of the lymphatics by these neoplastic cells. And so you have these neoplastic cells here in the lymphatics, and that can look like interstitial disease on the chest radiograph. Patients can be short of breath, so you'll have these neoplastic cells. If you suspect it, you can recommend transbronchial biopsy, because transbronchial biopsy does have a high positive yield for lymphangitic carcinomatosis. Now, there are various tumors. Any tumor can be associated with it, but lung cancer, breast cancer, these can give you predominantly unilateral lymphangitic carcinomatosis. And then you have upper abdominal tumors also that can give you lymphangitic carcinomatosis. There it tends to be bilateral, but any tumor can be associated with lymphangitic carcinomatosis. Chest x-ray may look normal or it may look like interstitial disease, might even look like interstitial edema sometimes with curly B lines on the chest radiograph. You might have pleural effusions or lymphadenopathy also associated with this. Remember that the lymphatics run in the periphery here of the secondary pulmonary lobule, so that's why you have interlobular septal thickening. They can also run along the airways here, so that's why you could have thickening parabronchial or parabronchovascular thickening also on CT scan in cases of lymphangitic carcinomatosis. But that nodular interlobular septal thickening is a very characteristic appearance for lymphangitic carcinomatosis, so if we see that, then certainly we need to consider that. And as we've said, it might be predominantly unilateral. This is a case of breast cancer. We have predominantly unilateral interlobular septal thickening with some background nodular pattern there. And then here's a close-up showing you that pattern. This is a case of lung cancer. So here's the tumor here, and the lymphangitic carcinomatosis is spreading out from the tumor. So lung cancer also might give you a predominantly unilateral pattern of lymphangitic carcinomatosis. Of course, pulmonary edema is the most common thing that can give you interlobular septal thickening, although here it tends to be smooth, and of course that will give you an interstitial pattern on the chest radiograph. So you look for pleural effusions, big heart, but this is the most common cause of smooth interlobular septal thickening. So here we have a 50-year-old woman with shortness of breath, and the chest radiograph shows
Bilateral interstitial.
yeah, bilateral surprise. There's interstitial opacities predominantly where?
Basilar.
Yeah, predominantly within the lower lungs. And this patient gets a CAT scan, which shows what?
Cysts at the basis of the lung.
What are you going to call those cysts? What do you think these cysts represent? Honeycombing, right. So this is pretty extensive honeycombing at the basis. So what do we think is wrong with this patient?
UIP.
Well, later on in the lecture, we're going to talk about that. But is there another finding?
The airway? I mean,
Airway?
the esophagus.
Yeah, what about the esophagus?
The esophagus is dilated.
The esophagus is dilated, so what do you think this is?
It has scleroderma.
Yeah, this is scleroderma, okay? So we'll talk later on about, are there ways to differentiate honeycombing from scleroderma versus honeycombing from idiopathic pulmonary fibrosis or UIP. But on the boards, it's a favorite case to show you interstitial disease, honeycombing. You have to notice the dilated esophagus, and then that's what should make you suggest scleroderma, underlying connective tissue disease as the abnormality. Here's another patient who's short of breath. The chest radiograph demonstrates
Peripheral interstitial opacity.
right, they're peripheral interstitial opacities, predominantly at the upper lungs or lower lungs.
Lower lungs.
Yeah, mostly lower lungs, but notice how markedly peripheral this is. You get this kind of L-shaped distribution of the interstitial disease. Okay, and then here on CT, what do we have on CT?
Peripheral honeycombing.
Yeah, so there's peripheral subpleural honeycombing. So this is the classic appearance of
NSIP.
what?
NSIP?
No, not NSIP, no.
UIP.
UIP. This is UIP. You have peripheral subpleural honeycombing. This is the classic appearance of UIP. So, of course, the disease associated with this would be, what's the disease? What's the topic of the lecture? Idiopathic interstitial pneumonias, right? So,
Rheumatoid.
not rheumatoid, although it can, but if we're talking about idiopathic interstitial lung disease, IPF, idiopathic pulmonary fibrosis, right? So this gets us into the topic of the idiopathic interstitial pneumonias. The definition of what these are is not a very satisfying definition, group of non-neoplastic, non-infectious lung diseases resulting from damage to the lung parenchyma by varying patterns of inflammation and fibrosis. These are clinical, radiologic, pathologic entities, meaning that to arrive at the diagnosis, you need the clinical input, you need the radiology, you need to correlate that with the radiology findings, and many times also with the pathology from biopsy. So definitive diagnosis requires a multidisciplinary approach. So at many centers, they have interstitial disease conference where it's an interdisciplinary conference between pathology, radiology, and the clinicians, where they present cases and try to arrive at a consensus diagnosis for what the interstitial disease is. For this very reason, is that it really does require a multidisciplinary approach. Now, for the idiopathic interstitial pneumonias, the original classification goes back to 1968 from Lebo, who was a pathologist at the University of San Diego, UCSD. And he described 5 patterns of interstitial disease, but these weren't really diseases, more they were responses of the lung to injury. And so that's what we have to keep in mind when we discuss these interstitial lung diseases, that the patterns that we look at may not be actual separate diseases, but may represent the way the lung responds to injury, since the lung can be limited in terms of how it responds to injuries. And so in Lebo's original classification, UIP was usual interstitial pneumonitis. Now, why did he call it UIP? It was the most common, right. So what would happen was, they would do a biopsy and they'd go down to pathology and what do you see? I see interstitial pneumonitis. What kind? The usual kind. It was the most common. That's why it's called UIP. DIP, discriminative interstitial pneumonitis, so we get into this alphabet soup and we'll talk about what these terms mean as we progress. BIP, he called it BIP, came to be called BOOP, but now we call it cryptogenic organizing pneumonia as an idiopathic disease, or organizing pneumonia as the histologic pattern. LIP, or lymphocytic interstitial pneumonitis, and what he initially described as giant interstitial pneumonitis, or GIP, we now know is not an idiopathic interstitial pneumonia, it's a hard metal pneumoconiosis, so this is no longer classified as an idiopathic interstitial pneumonia. So GIP, where we get these giant cells within the interstitium, these giant multinucleated cells here. So this now we know is a hard metal pneumoconiosis. It can be associated with exposure to cobalt or tungsten, and you can get interstitial lung disease, and of course the history is going to be important here in terms of arriving at the diagnosis. So this is not an idiopathic interstitial pneumonia, but the only way you really can arrive at the diagnosis is with the clinical history, in addition to showing fibrotic changes there on your imaging studies. Now, since then, there have been other interstitial diseases described, and again, we get into the alphabet soup, and we have to be familiar with what these terms mean. AIP for acute interstitial pneumonia, NSIP for nonspecific interstitial pneumonitis or pneumonia, RBILD, respiratory bronchiolitis-associated interstitial lung disease, PPFE, which is the most recently described idiopathic pleural parenchymal fibroelastosis. What's the difference between RB and RBILD? Yeah, so RBILD is when it is symptomatic and you want to give the patient a diagnosis of a disease, we call it RBILD. And RB, respiratory bronchiolitis, is a finding that you can see on imaging or on pathology in patients who smoke where they have parabronchial inflammation. They're not necessarily symptomatic. In that case, you would just call it respiratory bronchiolitis. Okay? Now, it turns out not all of these are idiopathic. We know that DIP and RBILD are associated with smoking. Whether LIP exists as an idiopathic disease is somewhat controversial because in the majority of cases, this is associated with some underlying autoimmune disease, this histologic pattern of infiltration with lymphocytes in the interstitium. And then not all are predominantly interstitial, even though when we think of interstitial disease, we think of that reticular pattern of interstitial opacities. AIP, DIP, COP, all of these can give you alveolar consolidations on imaging. The most important thing is that we want to be able to differentiate idiopathic interstitial pneumonias from hypersensitivity pneumonitis and underlying collagen vascular disease, because the treatment is going to be different. So this is something that you want to keep in mind as you're evaluating these cases. Okay? Now, the most recent update of this goes way back to 2013, this consensus statement by the American Thoracic Society and the European Respiratory Society, official update on and a classification of the idiopathic interstitial pneumonias. So this we do have to be familiar with. We do have to know that the idiopathic interstitial pneumonias are grouped into 4 categories. We have the chronic fibrosing idiopathic interstitial pneumonias, and there we have IPF and NSIP. We have smoking-related idiopathic interstitial pneumonias, DIP, RBILD, acute or subacute IIP, COP and AIP, and the rare idiopathic interstitial pneumonias, LIP and PPV. So that is a classification scheme that we have to be familiar with. In terms of terminology, there might be in some of these cases a difference between the histologic pattern or the pattern that we might describe on imaging versus the clinical syndrome. So the clinical syndrome is the actual clinical diagnosis. These terms here are the histologic pattern. This is what the pathologist would describe or what we might describe on imaging. So UIP is the histologic pattern or a pattern that we might see on imaging, and the clinical disease associated with that, the idiopathic interstitial pneumonia associated with that, is idiopathic pulmonary fibrosis. For NSIP, the terminology is the same. The histologic pattern of organizing pneumonia, that is the pattern associated with the idiopathic interstitial disease. Cryptogenic organizing pneumonia used to be called BOOP, but now we call it cryptogenic organizing pneumonia. The histologic pattern of diffuse alveolar damage, essentially ARDS, that is associated with the clinical syndrome, the clinical idiopathic interstitial disease, acute interstitial pneumonitis. DIP and DIP are the same. RB, RBILD, very similar. LIP, LIP the same, and PPFE, PPFE. There, the terms are the same. Now, reversible and self-limited, we can see that with respiratory bronchiolitis, interstitial lung disease, reversible with risk of progression. We can see that with cellular NSIP and some fibrotic forms of NSIP, DIP, and COP. Stable with residual disease, we can see that with NSIP. Progressive irreversible disease with potential for stabilization, we can see that with some fibrotic forms of NSIP. Progressively irreversible disease despite therapy. So IPF is the worst. That tends to have the worst prognosis because that can't progress despite treatment. And then there are the more fibrotic forms of NSIP, also those can progress despite treatment. Okay? Now, in terms of the approach as radiologists, in most cases we're going to be dealing with the appearance of these diseases on high-res CT. So we want to be able to describe the findings using standard terminology. We want to determine the distribution of disease, axial and craniocaudal. Axial meaning, is it perihilar central, or is it more in the periphery, versus craniocaudal, top of the lung, bottom of the lung. One of the most important things is you want to rule out UIP. We want to decide, are the findings typical of UIP or not typical of UIP? And we'll talk about why that is important. Fibrosing versus non-fibrosing disease. So honeycombing, traction bronchiectasis, architectural distortion, volume loss, all of these on CT are evidence of fibrosis, especially traction bronchiectasis, one of the most important things that you'll look for. And then there can be ancillary features that can point you to an alternative diagnosis, not an idiopathic interstitial pneumonia, cysts, perilymphatic nodules, etc. All of these things that you need to be careful to look for, because these can point to an alternative diagnosis. So you have to keep all of this in mind as we are approaching a high-res CT scan. So for CT findings not associated with idiopathic interstitial pneumonia, the finding of cysts, what diagnosis would that point you towards?
Emphysema.
What? Yeah, so that's emphysema, but here we're talking about actual cysts, lung cysts.
PCP.
So Langerhans cell histiocytosis, what other disease? What other interstitial disease? Which is not an idiopathic interstitial pneumonia. LAM, right. Lymphangiomyomatosis. Perilymphatic nodules. Sarcoid, right. What other disease might be associated with perilymphatic nodules? Yeah, lymphangitic carcinomatosis, right? Now, you might wonder, why isn't sarcoid an idiopathic interstitial pneumonia, right? It kind of fits, but it's not. It's not an idiopathic interstitial pneumonia. Central lobular nodules. So especially if we have ground glass central lobular nodules, what do we think about there? Well, central lobular nodules you might see with LCH, that's true also. But if you have ground glass central lobular nodules, especially associated with air trapping, you might think of
subacute hypersensitivity.
Yeah, subacute hypersensitivity pneumonitis. Also, you can have central lobular nodules in a tree and bud pattern. What does that point you towards? Small airway disease, right? So bronchiolitis, infections. So anything that gives you recurrent infections of the small airways, TB, atypical mycobacterial disease. Air trapping, if air trapping is the predominant abnormality in a patient with shorter breath. You mentioned emphysema, small airway disease. What other disease, especially if there's fibrosis mixed with air trapping? What else do we need to consider there? Fibrosis and air trapping. Well, CF gives you bronchiectasis. Also hypersensitivity pneumonitis. So you always have to think about hypersensitivity pneumonitis. So cyst, LCH LAM, perilymphatic nodules, sarcoid, lymphangitic carcinomatosis, some cases of lymphoma, central lobular nodules, HP, infection with tree and bud, air trapping, hypersensitivity pneumonitis. Also, if air trapping is the predominant abnormality without fibrosis, we can see that with small airway disease and also bronchiolitis obliterans. So starting with UIP, which is associated with that pattern associated with idiopathic pulmonary fibrosis, there's an insidious onset of progressive shortness of breath, cough, restrictive lung disease. Bad 5-year survival can be as bad as 20% even after therapy. Causes of death, the most common cause of death, of course, is respiratory failure. Interestingly, cardiovascular disease, the second most common cause of death. It's thought that the chronic hypoxia accelerates underlying cardiovascular disease. And then lung cancer is the third most common cause of death. The extensive scarring can predispose patients to lung cancer. So we have to have a high index of suspicion for lung cancer whenever you're reviewing CT cases of patients with idiopathic pulmonary fibrosis. So with UIP, it's a process of repetitive injury and repair. So we have injury, we have fibroblast proliferation, collagen deposition, and then there's recurrent injury, and it just progresses. So you'll have alternating injuries of injury, alternating areas on histology of injury and repair. The fibroblastic focus is a finding that they look for on pathology, which is typical of this disease, this focus of fibroblasts they are collecting. So on pathology, they will find alternating areas of normal lung tissue, acute injury, repair, and fibrosis. So this is a temporally heterogeneous process, meaning that there are different areas of the lung in different stages of injury. So it's an ongoing process. And the fibroblastic focus is also another finding that the pathologists will be looking for. In end-stage disease, then you get the honeycombing, and you'll get these cysts, which are these areas of honeycombing, predominantly in the periphery of the lungs. On the chest radiograph, we have interstitial disease, reticular opacities, predominantly in an L-shaped distribution like this. Worse at the lung bases, but especially in the periphery of the lungs. And if you look real close, you might see these little holes, look like ant holes. Those are the areas of honeycombing. And low lung volumes is also associated with this disease. So on the chest radiograph, this L-shaped distribution of interstitial disease is very characteristic of a UIP pattern or idiopathic pulmonary fibrosis. And when we look close, we can see all these little holes which represent the areas of honeycombing. Now, if you're not sure about interstitial disease on the frontal view, right, sometimes we're not sure, is it overlying soft tissue density? The lateral view is very helpful. So you look in the retrocardiac area, that should be a relatively clear area on the chest radiograph. So if you see interstitial opacities there, then that's pretty good evidence that you do have real lung disease in the patient. Another example, your typical L-shaped distribution of reticular opacities and interstitial disease. And then here's the CT correlate of that. You can see that reticular opacities predominantly in the periphery, and then here you can see your areas of honeycombing, which are these stacked cysts. Again, in these subpleural regions in the periphery, it tends to be worse at the lung bases in these patients. So the normal secondary pulmonary lobule in the center, you have the centrolobular airway, and then the centrolobular artery, which goes alongside the airway. The veins are in the periphery. And then this kind of a really high-res cut of what that looks like. So you have your vessel alongside the airway. We do have interlobular reticular opacities, which are normal. Usually these we do not see on high-res CT. When the patient has fibrosis, we get traction bronchiectasis or bronchiolectasis, and then you get distortion of all of these small airways within the secondary pulmonary lobule. This is what causes the honeycombing that we see on CT. So this honeycombing that we see on CT is a result of that fibrosis and the traction bronchiectasis. So this tends to be peripheral and subpleural. We may also have ground glass opacities associated with this. And then if you have ground glass opacity associated with areas of honeycombing, that ground glass opacity probably represents fibrosis. Whereas if you have ground glass opacity away from the areas of honeycombing, then that might represent more active interstitial disease. That's where you would want a direct biopsy because it's more likely to get a diagnostic biopsy specimen from those regions of the lung, whereas in regions of the lung where you have honeycombing, then you just have end-stage honeycombing, and it's hard for the pathologist to give you a diagnosis as to what the underlying disease is. So that peripheral subpleural honeycombing, very characteristic pattern of UIP, and again, the idiopathic disease, IPF, is what is associated with this pattern. Now, ground glass opacity as a finding of itself is a very non-specific finding, so there are many things that can cause it. Normally, when we look at CT, you're looking at a voxel, which is a summation of the density of a bunch of alveoli within that voxel. So normally, those alveoli are filled with air, so it's very low in attenuation, and you don't have ground glass opacity. But if you have atelectasis, then that can increase the attenuation of that voxel. That can look like ground glass opacity. If we have interstitial lung disease, where we don't have any disease actually within the alveoli, within the alveolus itself, but the interstitial thickening increases the attenuation of the voxel, that can give you ground glass opacity. If you have consolidation that's filling the alveolar spaces, whether it's cellular material or whether it's something else, that can also increase the attenuation of the voxel and give you ground glass opacity. So ground glass by itself is a very nonspecific finding. And then we also, when we're looking for fibrotic disease, in addition to the subpleural honeycombing, you also want to look for traction bronchiectasis or traction bronchiolectasis. So distortion of airways, stretching of the airways, that kind of beaded appearance of the airways tells you that the abnormality within the adjacent lung represents fibrosis. This ground glass opacity here then represents a fibrotic lung disease because of the traction bronchiolectasis. So that is a very important finding that you want to look for on your high-res CT scans. To differentiate dependent ground glass opacity from a real abnormality, you might need to do prone CT, and then here you can see that ground glass opacity persists, as opposed to ground glass opacity from dependent atelectasis. The normal patient, some ground glass opacity here, but when you turn the patient prone, it goes away. So that is just dependent atelectasis, as opposed to interstitial disease, where we have ground glass opacity here in the dependent portions of the lung, but when we turn the patient prone, it remains persistent, so then this represents interstitial lung disease and not dependent atelectasis. Now, the primary role for high-risk CT in the idiopathic interstitial pneumonias, we want to separate out the patients with typical findings of UIP or idiopathic pulmonary fibrosis from the other idiopathic interstitial pneumonias. So basically, we're trying to decide, are the findings typical of UIP or not typical of UIP? For most cases, aside from UIP, many other cases of idiopathic interstitial pneumonia might recommend or usually need biopsy to arrive at the diagnosis. But if the picture is classic or typical of UIP, and the clinical findings are typical of UIP or IPF, that patient will not require lung biopsy and can be treated for idiopathic pulmonary fibrosis. Even if a UIP pattern is present on lung biopsy to make a diagnosis of IPF, it's still important for the clinician to exclude other diseases like collagen vascular diseases, drug toxicities, environmental exposures, asbestosis, etc., because this can also give you a UIP pattern sometimes. So the diagnosis of these idiopathic interstitial pneumonias requires the input of the pulmonologist, radiologist, and pathologist, so really a multidisciplinary approach. So when you're approaching a case of interstitial lung disease on high-risk CT, first thing we want to decide is, do we think it's UIP or not? And then there are various classifications like typical UIP, probable UIP, indeterminate for UIP, or inconsistent with idiopathic pulmonary fibrosis. So looking at this CT scan, which of those categories would we pick?
B.
So why B?
I mean, so we don't have the honeycomb.
Right, so the one thing is you don't have honeycombing. So if we had the peripheral subpleural honeycombing, that is typical of UIP. So that makes it easy. So then we would go with that one. But why do we go with this one? One, you don't have honeycombing, but what do you have?
We have some interstitial opacities,
Yeah.
reticular opacities.
Right, you have reticular opacities, and the distribution is predominantly
In the bases, but we also see like
peripheral. Yeah,
peripheral.
it's that peripheral distribution of reticular opacities, and we also have some traction broncholectasis. So there is some evidence of fibrosis here. We have this peripheral distribution of reticular opacities, traction broncholectasis. We don't have findings that point us to another diagnosis. We don't see cysts, we don't see nodules, so we don't see anything that points to a diagnosis outside of IPF. So here you would go with a probable UIP pattern. So that's the first thing in terms of the approach to interstitial lung disease. So the UIP, the typical UIP pattern, reticular opacities, honeycombing, basal and peripheral, no inconsistent features. So if we have that, if we decide on that, and if the patient has clinical findings that are typical of idiopathic pulmonary fibrosis, lung biopsy is not necessary. The patient can be given a diagnosis of idiopathic pulmonary fibrosis and then can be treated. So in this example, we can see peripheral reticular opacities. We do have nice honeycombing here in the periphery, so that is a typical UIP pattern. A probable UIP pattern is if we have reticular opacities in the periphery, basal and peripheral, no inconsistent features, no features that point us to an alternative diagnosis. So here also, if the patient has clinical findings consistent with IPF, lung biopsy is not necessary. So here also the patient can be given a diagnosis of idiopathic pulmonary fibrosis and can be treated accordingly. So I've given you this table, and then this you would use when you're interpreting these high-risk CTs. Typical UIP, we've discussed typical UIP, we've discussed probable UIP, but then there might be findings that are indeterminate for UIP. So patients who have a typical UIP pattern, 90% of them will have idiopathic or will have UIP on biopsy. Patients with a probable UIP pattern, up to 80% will have a UIP pattern on biopsy. So that's pretty good. Indeterminate, now only 50% will have UIP, but it's not good enough to give them a diagnosis, at least on imaging, of IPF or UIP. And consistent with an alternative diagnosis, even if you have some of these other things, extensive ground glass opacities, nodules and cysts, air trapping, up to 50% can still have a UIP pattern on biopsy, right? So we're not very good at making the diagnosis in these cases. So that's why we want to concentrate on this end. If we think it's UIP, we want to come down on that because then the patient will not require a lung biopsy for treatment. There are these drugs that are used, approved therapies for idiopathic pulmonary fibrosis. And if we say that the findings are typical or probable for UIP, then the patient can undergo therapy for idiopathic pulmonary fibrosis without undergoing lung biopsy. So honeycombing, typical of UIP, peripheral subpleural honeycombing. In a case like this, we might wonder, is there honeycombing? Yes, no, plus, minus, I'm not sure. But there are reticular opacities. It does have a peripheral distribution. So here we're happy with a probable UIP diagnosis. So again, this patient may not require lung biopsy. Here, we have ground glass opacity and traction bronchiectasis, but we really don't have a peripheral distribution, in this case of the abnormality. So here we don't think this is going to be IPF, or at least the imaging is not pointing us in the direction of IPF. Right? We'll talk about this in a little bit. Here we have air trapping, mosaic attenuation, extensive air trapping. We do have some evidence of fibrosis, right? But with the air trapping mixed in with this, again, we have to think of something else besides idiopathic pulmonary fibrosis. What would we consider in this case? Hypersensitivity pneumonitis. So in this case, you have to bring up the possibility of hypersensitivity pneumonitis. Okay? So here's a patient who's short of breath. What do we see on the chest radiograph? Right. So what are you thinking about here? Well, do you have alveolar consolidations or do you have reticular opacities? Well, these are kind of reticular here. Right? These are more reticular. This is scapula here. Right? These are reticular opacities in the periphery. Yeah, so these are interstitial opacities. Chronic shortness of breath with this chest X-ray appearance, you would be thinking about which one? We just spent 20 minutes talking about UIP. So would you consider UIP here?
I don't like that there's
Absolutely, you should consider UIP. And if you're not considering UIP, I've just wasted the last 20 minutes with you guys.
But, okay.
But what? What is your concern?
I mean, my concern is, not a concern, it's just, I don't see them much, like, in the basis, like you showed us. Like,
well,
pattern,
you have, do you agree there are reticular opacities here?
Mm-hmm. Okay,
Yes. Here's the CT, right? So on the CT, again, we have these areas of honeycombing with reticular opacities, right? Also have some emphysematous disease in this patient. But there's another important finding on the CT, and what is it? Well, they're a bullae, right? But what other important finding is there on the CT? Nobody can see another finding on the CT?
I don't know what that hyperdense thing is.
Yeah, I mean, what do we think this is? Any idea? That's a lung cancer. Okay? That's a mass. That's a lung cancer. Go back to the plain film. Do you see it on the plain film? It's this guy over here. Okay? So what's the point? The point is when you're dealing with idiopathic pulmonary fibrosis or fibrotic interstitial lung disease, you have to have a high index of suspicion for lung cancer. This is the third most common cause of death in these patients. This is a lung cancer. And this patient also has this idiopathic pulmonary fibrosis.
Why does it look so
Oblong and funny?
hyperdense?
Well, these are lung windows. I mean, it's not calcified, right? It's not quite calcified, but these are lung windows. So, lung cancer, third leading cause of death in patients. Interestingly, smoking is associated with IPF. This patient was a smoker, that's that bullous lung disease with the IPF, and also would increase your risk for lung cancer. What complication of IPF do we have here? Pneumothorax, yeah. So with this honeycombing, especially in the periphery, right, any of these can break into the pleural space and can give you a pneumothorax. So that you can also see with IPF. Here's a patient who had idiopathic pulmonary fibrosis, came back 3 months later with worsening shortness of breath and dyspnea. What do we see here now?
On the left, we see some peripheral hazy opacity or ground glass opacity.
Yeah, so mostly ground glass opacities, right? And this is obviously new since the prior study, right? So, go ahead.
There's like honeycombing on the right.
Yeah, there is honeycombing here. So we got some honeycombing there, some reticular opacities, but all of this superimposed, and some honeycombing here too. So all of this superimposed ground glass opacity on the background pattern of IPF, what complication is this? What is this called? What?
It could be pneumonia.
Well, of course, you can get viral pneumonias, and anybody can get them, right? Especially nowadays. But what specific complication associated with IPF? What do we call this?
Massive pulmonary fibrosis or
Something
something like that? I don't know.
like that? I don't know. No. Acute exacerbation, right? This is acute exacerbation of IPF or accelerated IPF. So these are patients who have idiopathic pulmonary fibrosis, and essentially they come back with ARDS, an ARDS picture superimposed on their idiopathic pulmonary fibrosis. And this can manifest as consolidations or ground glass opacities superimposed on the IPF. And, they can be severely short of breath, may require intubation. Sometimes it can be a terminal event. So this is acute exacerbation, or accelerated IPF is another term for this. Okay, so this patient is short of breath. We're concerned about interstitial lung disease. We do high-res CT. The first question is, do we think this is UIP or not typical of UIP or not UIP? UIP or not UIP? Not UIP. What are the findings on the CT that we have here? First, is it a fibrotic lung disease? We have one vote no. What do you look for to say it's fibrotic lung disease? Is there traction bronchiectasis? Yes, there is. Right? You have peribronchial thickening. You have this irregularity of the airways here, right? This is traction bronchiolectasis. So there is fibrotic lung disease here, right? Is there honeycombing? No. Are there reticular opacities predominantly in the periphery?
No.
Not so much. What is the predominant abnormality? Ground glass, right? So what are we thinking about here if we're thinking about idiopathic interstitial pneumonia? Yeah, here you think about NSIP, right? So, and the other finding associated with NSIP is what? Probably the most specific finding associated with NSIP is subpleural sparing, right? So if you have not the best example, but if you have subpleural sparing, that's another finding that is associated with NSIP. Now, if you want to look for fibrosis traction bronchiolectasis, you can do this, which brings it out very nicely, right? Don't you like that? Isn't that nice? Isn't that pretty? What is this? That's a MINEP reconstruction. So if you're looking for airways, if you're looking for low attenuation structures, then you can do MINEP reconstructions. Okay, and that can show you that very nicely, right? So this is NSIP. Now, NSIP is a very, as the term suggests, a very nonspecific finding. We can find it with all kinds of diseases on biopsy, the histologic pattern. We can see with all kinds of diseases on biopsy. Not important for you to memorize the list, okay? But the idiopathic form of NSIP, so this is progressive shortness of breath. The mortality is not as bad as with IPF. It can respond to treatment. The prognosis depends on the degree of fibrosis. So the more extensive fibrosis has a worse prognosis when we're dealing with NSIP. So with cellular NSIP, they have a good 5-year survival. Fibrotic NSIP, not so good, but still not as bad as UIP. Okay? So the NSIP pattern, here it's temporally homogeneous. So there was one incidence of lung injury, and the lung is at the same stage of repair at various sites of biopsy. No fibroblastic foci, no honeycombing. There's this cellular interstitial pattern with dense collagen on biopsy. So on chest radiographs, we might see ground glass, we might see a basilar distribution of opacities, reticular opacities. On CT, predominantly ground glass, traction bronchiectasis or bronchiolectasis, subpleural sparing, a very specific finding that can be associated with NSIP. So we like to look for that, the subpleural sparing. No honeycombing. A honeycombing, if present, can be associated with fibrotic NSIP. The more fibrotic the disease gets, then you can see honeycombing. And then here, we're not going to get the diagnosis right. That looks like UIP over there. Okay. So there can be cases of NSIP that look like UIP. There can be cases of UIP that look like NSIP, and we're not going to get it right. And that's why these patients are going to require a lung biopsy to get to the right diagnosis. Okay. And then the more fibrotic form of NSIP, that can be associated with more fibrotic disease. The more cellular forms of NSIP, more alveolar opacities, more ground glass opacities, the more cellular forms of NSIP. So that correlates somewhat with the biopsy findings. So continuing with the idiopathic interstitial pneumonia. So if we look at this chest radiograph and this CT, the question is which of the idiopathic interstitial pneumonias is represented here? So first, what's the finding? How would we describe the abnormality?
Bibasilar consolidations.
So you have consolidation. So you have airspace disease, and so that's the first thing, as opposed to prior types where we saw mostly interstitial abnormalities. And what else about these opacities, these consolidations, should be remarked about? Dan?
Bibasilar, their distribution is like in the lower lung.
What about central versus peripheral?
They're peripheral.
They're peripheral. So you have peripheral consolidation. So which of the idiopathic interstitial pneumonias are we talking about here?
NSIP.
No, not NSIP. We don't see ground glass really as a predominant abnormality or traction bronchiectasis, right? So which of the idiopathic interstitial pneumonias would this be? Sultan, I saw you studying the slides yesterday. Did we remember anything?
Organizing?
Yes, organizing pneumonia. So this would be cryptogenic organizing pneumonia. The importance of that diagnosis is it does respond to steroids. So at presentation where you would have these consolidations, many times these patients are mistaken for having pneumonia. They're given antibiotics, they don't get better. But if we recognize the appearance, they can treat with steroids, and then there's a marked improvement after steroids. So cryptogenic organizing pneumonia used to be called BOOP. Organizing pneumonia is the pathology, the histologic pathology associated with this, and some other terms that have also been used to describe this disease. So the problem here is that the process begins in the alveolar air spaces. So even though it's been called BOOP, it primarily starts as an organizing pneumonia in the air spaces and then secondarily invades the airways. That's where we get the bronchiolitis obliterans component here from the description. So we have these fibrotic granulation plugs or tissue polyps that invade the air spaces, and on pathology, they will see that in the air spaces, and that's where they get the BO part of that, the bronchiolitis obliterans. The organizing pneumonia is this part out here, which is really the predominant process here. So you'll get granulation tissue overgrowth, which then invades here the airways secondarily. The architecture is preserved, is temporally homogeneous, meaning that the different parts of the biopsy look very similar. Now, an organizing pneumonia pattern can be associated with many other diseases, not necessary for you to memorize the list, but the point is, although if it's idiopathic, we call it cryptogenic organizing pneumonia, it can be found in many other diseases, just about any disease you can name might be associated with an organizing pneumonia pattern on biopsy. For that reason, the presence of organizing pneumonia on a transbronchial biopsy is only of limited value without clinical and radiological correlation. So again, getting back to what we said earlier about idiopathic interstitial pneumonias, that it requires it requires kind of an interdisciplinary approach between the clinician, the pathologist, and the radiology findings. So usually these patients present with cough, progressive dyspnea, low-grade fever, and many times they'll have consolidations on the chest radiograph, so they're assumed to have pneumonia, they're treated with antibiotics, they don't get better. That's why it's important to make the diagnosis, because the proper treatment is with steroids for these patients. So the typical findings on imaging: peripheral consolidations, it is airspace disease, also might be peribronchial in terms of distribution also. So you might have peribronchiolar consolidations, but this appearance with the peripheral consolidations is very characteristic of organizing pneumonia. And if it's idiopathic, then we call it cryptogenic organizing pneumonia. All right, so for those of you that just walked in, there's a particular sign that is associated with COP. What is the sign that is demonstrated here? The reverse halo sign, yes. So why do we call it a reverse halo sign?
Because it's the opposite of the halo sign.
What's the opposite? What is reversed?
So we have the ground glass in the middle and the...
Yes, so it's denser in the periphery. So as opposed to the halo sign where you have a consolidation or nodular opacity and there's ground glass in the periphery, with the reverse halo sign, we have this ground glass attenuation here, more so in the central area of the lesion, and as you go to the periphery of the lesion, it gets denser. So that is called the reverse halo sign. So is this specific for COP?
No.
No. What else can give you this? You just told me it's not specific for COP. So.
I'm not sure. I know that it's not specific.
All right, so there are many other things that can do this. I mean, around here I've seen it associated more with aspergillosis than COP. It can also be associated with, of course, BAC, or mucinous producing adenocarcinomas, infections, etc. Pulmonary embolism, right, with infarct can also give you a reverse halo sign. So there are other things that can give you the reverse halo sign, but it is a finding that is associated with COP, so that's something that might come up on an exam. So when it was first described, it was thought to be pathognomonic, but of course that turns out not to be true. So it's not a specific finding, but it can be associated with COP. Another appearance we can see with cryptogenic organizing pneumonia is this perilobular pattern, where we have this thickening, interlobular thickening, but it's kind of irregular. So it doesn't look like interstitial edema. It doesn't really look that nodular. It doesn't look like interstitial tumor, but it's this bizarre kind of interlobular septal thickening. So this has been called a perilobular pattern. This can also be associated with COP. Okay. So consolidations can get worse despite antibiotics. They send the patient to imaging. We see peripheral consolidations. We suggest a diagnosis of organizing pneumonia. By the way, what else might you consider if you have peripheral consolidations? Another disorder that we covered earlier?
Chronic eosinophilic.
Yes, chronic eosinophilic pneumonia. You might consider that also. Here they treat the patient with steroids. The patient gets better on the follow-up exam. So that was COP. If I tell you this patient presented with shortness of breath, required intubation, shortly thereafter, you can see consolidations on the chest radiograph, dependent consolidations, ground glass opacity on the CT. Which of the idiopathic interstitial pneumonias are we discussing here?
Maybe AIP.
So this is AIP, acute interstitial pneumonitis. So the way to understand AIP, what's the best way to understand AIP?
I think of it like kind of like a spectrum of ARDS.
So it's idiopathic ARDS. So AIP is idiopathic ARDS. We have the same physiologic findings, the same imaging findings as ARDS. You can have these consolidations that are kind of dependent because of the weight of the lung. And these patients go into respiratory failure. So idiopathic ARDS used to be called the Hammond-Rich syndrome. Originally, it was thought to be a form of idiopathic pulmonary fibrosis, but that turns out not to be true. So it's an episode of lung injury by some unknown cause, essentially ARDS of unknown cause. Now, with UIP, which we've covered earlier, where there's ongoing repetitive injury and repair, with AIP, there's one episode of massive injury, and then there's repair. There's the diffuse fibroblast proliferation that occurs there. And so, as opposed to UIP, where the interstitial fibrosis occurs in the interstitium, the fibroblasts proliferate in the interstitium, with AIP, we get organization. So the stuff that spills out into the alveolar spaces becomes organized then into the alveolar walls. That's called fibrosis by accretion, and that's the pathology of AIP, but it's the same as ARDS. It has a very high mortality rate. We'll see consolidations bilaterally on the chest radiograph, looks just like ARDS. We've gone through the different phases of ARDS before, so I'm not going to go through that again. So we have the subacute proliferative phase, the chronic fibrotic phase, and then in the fibrotic phase, you can see that we have fibrosis here filling up the periphery of the alveolar air spaces, and you can imagine how that's going to impair oxygenation. So that is it's the pathology of diffuse alveolar damage, which is what we see with ARDS. So we'll have progressively worsening consolidations, as you can see in this example, and the patient goes into respiratory failure. And what is a hallmark of ARDS on the CT scan? What is the hallmark of ARDS on the CT? What am I illustrating here?
Ground glass.
Well, this is more than ground glass. You have air bronchograms, right? These is airspace disease, consolidations. But what is the... Yeah, this gradient, this gravitational gradient of opacity, right? That it's denser in the dependent portions of the lung, because with ARDS, the lungs get very heavy and stiff. And what we're looking at, a lot of this is actually atelectasis. So that gravitational gradient of opacity towards the dependent portions of the lungs is a hallmark of ARDS on imaging. So it helps to recognize that, okay? And then when it goes into the fibrotic phase, we can see some traction bronchiectasis, as you see in these examples. We don't usually get honeycombing with AIP or with ARDS. All right, so moving on. So here it's a 48-year-old smoker with shortness of breath. First, describe the finding, and then tell me which of the idiopathic interstitial pneumonias we're talking about here. The finding is, Murad, looks like you've been studying for the boards.
Bilateral ground glass opacity.
Yes, so we have ground glass opacities, yes. Go ahead.
In the lower loop.
Okay. Also somewhat towards the periphery, maybe. So which of the idiopathic interstitial pneumonias here in a smoker? All right. DIP. So DIP of discriminative interstitial pneumonitis. So that can be found in smoking. So it's really a misnomer in terms of the terminology, because when Lebo originally described this, he thought that these cells filling the alveolar spaces were desquamated pneumocytes. It turns out they're not. They're really macrophages that are recruited to the lung as some kind of reaction to smoking. So we get this accumulation of these macrophages in the alveolar air spaces. So there was a proposal to actually change the name to alveolar macrophage pneumonia to more accurately describe the pathology of what's going on here, but that never caught on. So we're still stuck with this misnomer, DIP. So these are really not desquamated pneumocytes. These are macrophages that are recruited to the alveolar air spaces as a result of smoking. Temporally homogeneous, meaning that the different parts of the lung, again, have similar histology here. So it's rarer than idiopathic pulmonary fibrosis. 90% of these patients will be smokers, so this is associated with smoking. Less likely to progress to fibrosis, so this is can be treated with steroids, or we ask the patient to stop smoking, and it does get better. So you can have these kind of ground glassy opacities. The patient can be symptomatic, short of breath, and on pathology, we will have these alveolar macrophages. So it's ground glass. It might be in the periphery. You might have these areas, these lobular regions of air trapping. Again, these patients are smokers, so they might have some underlying emphysema, small airway disease, with underlying air traffic. So that's what we see with DIP. We usually don't see honeycombing with DIP. And then it does respond to steroids and to smoking cessation, so it does get better. Okay. Now, if I show you this, I tell you again, we have a smoker with shortness of breath. What's different about the appearance here, and which of the idiopathic interstitial pneumonias do we consider here? What's different about the appearance? So now we have centrilobular ground glass opacities, and so which of the idiopathic interstitial pneumonias?
ILD.
Yes, so RBILD, respiratory bronchiolitis, interstitial lung disease, right? So the pathology is really the same. Again, these are macrophages that are recruited, but they tend to occur around the centrilobular region, around the airway, as opposed to more diffuse, which is what we see with DIP. Now, when you have centrilobular ground glass opacities, what else is in the differential diagnosis? Hypersensitivity pneumonitis, especially subacute hypersensitivity, or just hypersensitivity pneumonitis. If I give you the same history, why would you prefer RB as opposed to hypersensitivity pneumonitis? What does the smoking have to do with it? What?
It's associated with RBILD.
Well, smoking is associated with RBILD, but what about hypersensitivity pneumonitis?
That's organic antigen.
Well, I'm not asking you for the pathology, I'm asking you about this.
Oh, the presentation?
Is smoking associated with HP? Yes or no?
No.
No, actually it's protective. So patients who smoke are less likely to get hypersensitivity pneumonitis. So if you have a smoker with centrilobular ground glass opacities, it's better to go with respiratory bronchiolitis than hypersensitivity pneumonitis, okay? So here we have the accumulation of these macrophages around the centrilobular airways. Again, these patients might be symptomatic. It also improves with stopping smoking or with steroids. And again, this usually does not progress to fibrosis. So we get these macrophages within the airways or surrounding the airways with respiratory bronchiolitis. So this is more common than DIP, and it's actually a common finding on histology in smokers. So respiratory bronchiolitis as a histologic finding is very common in smokers. We call it RBILD when? What's the distinction between RB and RBILD? Symptoms, right. So RBILD is if the patients are symptomatic, interstitial lung disease, respiratory bronchiolitis, interstitial lung disease, okay? So again, it's probably the same spectrum as DIP, only the location of where these macrophages accumulate is different. So alveolar air spaces for DIP around the centrilobular bronchiole or in the centrilobular bronchiole for RBILD. It's been called the smoker's lung on the chest radiograph. You kind of have these reticulonodular opacities, dirty-looking lungs on chest X-ray, the smoker's chest appearance, and then centrilobular ground glass opacities on CT. These can be very subtle. Actually, not unusual to see this in smokers, so usually it represents respiratory bronchiolitis. And you can also make this diagnosis without biopsy if on bronchoalveolar lavage fluid they have macrophages, the pigmented macrophages, so-called smoker's macrophages on BAL if these patients get BAL. So respiratory bronchiolitis, centrilobular ground glass opacities, it does get better if the patient stops smoking. Okay, the findings here on the chest radiograph, we have, what do we have on the chest radiograph? Of course, you can cheat and look at the CT, but well, we have reticulonodular opacities on the chest radiograph. The finding on the CT, what's the finding on the CT? That a normal CT? No, we don't really have interlobular septal thickening. It's not, the predominant abnormality, is it reticular or nodular? It's nodular, right? So, do you see nodules here? Yes or no?
On the CT.
Yeah, on the CT.
Yeah.
Yes, right. These are all nodules. See those? Okay, we have nodules. What would you say about the distribution of the nodules? Well, you think that you would go with central ovular for this distribution? What's all right? What's the first thing we ask? You ask yourself, self, are the nodules touching the pleural surfaces? Yes or no?
Yes.
They are touching them. So what does that mean?
Either perilymphatic or diffuse.
Right. It is not central ovular, right? So it's either perilymphatic or random. So what would you suggest here? I agree. This one might be a little bit tougher, but yeah, if you look at this, it's out. What is this outlining? See how those nodules are?
Secondary.
Yeah, these out nodules, some of them seem to be outlining secondary pulmonary lobules. So perhaps perilymphatic in this case, all right? So maybe a perilymphatic distribution of nodules, right? Or maybe, you know, if you go with random distribution, we've talked about what that could be. Maybe perilymphatic here, but what is there another finding on the CT? Is there anything else on the CT?
The mucoid infection,
What?
like mucoid infection in the.
Well, what did you say? Mucoid infection? Mucoid impact. Where do you see mucoid infection on the CT? For mucoid impaction, we look for branching tubular opacities, right? That we don't think are blood vessels. So where do you think you see mucoid impaction here?
I was thinking this is mucoid infection.
Well, yeah, but where do you think you see mucoid impaction?
In the lower lobe.
Right lower lobe? These guys?
On the top one.
On the top one?
Yeah.
Yeah, these are all blood vessels. Okay.
Pulmonary cysts.
Cysts, right. So look at these. You have these air-filled thin-walled lesions. You have air-filled cystic lesions. Okay. So which of the idiopathic interstitial pneumonias can give you nodules and cysts? Lymphocytic interstitial pneumonitis, right. So that would be the one that you would go with here, LIP, lymphocytic interstitial pneumonitis. So LIP, this as an idiopathic interstitial pneumonia is somewhat controversial, whether this really exists as an idiopathic entity, because most cases we find LIP associated with underlying autoimmune disease, right? Especially, so what is the typical underlying disease that we might find this associated with? Not so much scleroderma, but Sjogren's, right? So associated with Sjogren's, but it can be associated with other underlying autoimmune diseases, is when we usually see it. So whether it really exists at an idiopathic entity is still somewhat controversial, right? Doesn't seem to be pre-neoplastic, it's idiopathic, although it can be with Sjogren's syndrome, so that also is somewhat questionable. But it's proliferation of polyclonal lymphocytes in the interstitium. That's the pathology of lymphoid interstitial pneumonia. Whether it exists idiopathically, again, somewhat controversial, but we do find it associated with autoimmune disease, especially Sjogren's, and then I've listed some others. It is an AIDS-defining illness in children, so it can be associated with HIV, even in older patients. LIP can be found in those patients. Right? So, as an idiopathic entity, maybe a response to steroids might progress to fibrosis. Again, this is all very questionable. As an idiopathic entity, it does not seem to have a malignant potential. Also in AIDS, it doesn't seem to have a malignant potential, although in Sjogren's, it can be pre-malignant. LIP can be pre-malignant. If we find LIP, the important thing is to rule out any underlying autoimmune disease, because in most cases, LIP is secondary to an underlying autoimmune disease. So what we have is diffuse polyclonal proliferation of lymphocytes within the interstitium and lymphoid follicles, as demonstrated here on the histology. Okay. It can give you a varied appearance, most variable appearance as far as the idiopathic interstitial pneumonia is on imaging. So we can have alveolar opacities, reticular nodular opacities. Here you have some larger nodular opacities, so we can get that. You can get smaller nodular opacity. The most specific finding, though, seems to be the cystic air spaces. So the cysts seem to be the most specific finding that can be associated with LIP. All right, so if we're discussing idiopathic interstitial pneumonias and we see cysts, then you might think of LIP in that case. Here are more examples of the cystic changes that you can see with LIP, right? So here are smaller cysts in this case, some larger cysts in this case. So that's why in Sjogren's syndrome, if we see a patient with cystic lesions in the chest, we will suggest LIP secondary to their underlying Sjogren's. More examples here, some ground glass and cysts. This responded to steroids. The ground glass got somewhat better, but you can still see that background cystic pattern there within the lungs. And here's kind of a spectrum: ground glass opacity, cysts, ground glass and cysts, all of these examples of LIP. So LIP, remember, cystic lesions can be associated with that. Oh, yeah. Do you usually get nodules with lymphangiolymatosis? No, you're confusing it with EG, with LCH. LCH starts out nodular and then the nodules cavitate to become cystic. That's LCH, right? Lymphangiolymatosis is usually purely cystic. All right. Although there is an exception, but we may get to that. Okay. The idiopathic interstitial pneumonia that gives you this upper lobe fibrotic change, PPFE, pleuroparenchymal fibroelastosis. This is the one, the most recently, discussed one. It's not a diagnosis you're going to make prospectively, right? So you see a CT or an imaging finding with these kind of changes. What are the diseases you're going to suggest? TB, you might think about upper lobe fibrotic disease. What else? Sarcoid, certainly. Sarcoid might be the first thing you talk about here, okay? So chances are you're not going to make this diagnosis prospectively, but it is idiopathic interstitial pneumonia, and what's characteristic about the imaging is this subpleural apical distribution of disease, right, with PPFE. So fibrosis in the subpleural regions, more in the upper lungs, somewhat high mortality rates, subpleural thickening, consolidations, traction bronchiectasis, upper lobe volume loss. All right, so that's PPFE. So in terms of the idiopathic interstitial pneumonias, know where they are different, and that's what we kind of stressed here. So for idiopathic pulmonary fibrosis, we're looking for honeycombing, reticular, peripheral, subpleural distribution, tends to be worse at the lung basis. For NSIP, predominantly ground glass, can be reticular. We're looking for traction bronchiectasis. Subpleural sparing is the most specific finding. For NSIP, you do not get honeycombing with NSIP. For COP or any organizing pneumonia, peripheral consolidations, there might also be peribronchiolar, but it's predominantly airspace disease, tends to be peripheral in distribution. AIP is just idiopathic ARDS, right? So consolidations, bilateral respiratory failure. DIP associated with smoking, ground glass opacities that might be peripheral and subpleural. For RB-ILD, very similar to DIP, only to distribution. Here we look for centrilobular ground glass opacities. For LIP, you could have nodules, ground glass, cysts, although the most specific feature for LIP are the cystic changes. And then PPFE is the distribution of disease, that upper lung subpleural distribution, especially in the apices, and then it's not, this one is not a diagnosis you will make, okay? This we've already covered, we've already talked about, but let me show you this interesting case. So if I show you these CT images and I ask you, do you think this is COP, NSIP, or UIP? Which would you go with?
NSIP.
Well, how would you describe the findings? What do you see? So we have peripheral ground glass opacities, right? We have peripheral ground glass opacities. What do we look for NSIP in addition to ground glass? Look for what? Traction bronchiectasis. Do you see traction bronchiectasis? Moretta's shaking her head no. So what are you going with, Murad? What are you going with here? Of those three, what are you going to go with? Speak up, we can't hear you.
I was between COP and UIP.
Yeah, well, COP or UIP, which?
Um, UIP.
What do we look for UIP? What do we want to see? Honeycombing, peripheral reticular opacities. Do we have that here? No. So we have mostly peripheral subpleural airspace opacity, somewhat ground glass. So of the three choices, the best choice is what? COP. And given that was your third choice for all of you, I'm very depressed after having gone through this detailed discussion of idiopathic interstitial pneumonia. COP, NSIP, or UIP? Well, what are the findings? How would you describe the abnormalities here? We have what? You have peripheral ground glass opacities, right? We do have traction bronchiectasis. Do we have honeycombing? No? So what do you favor? It is a fibrotic lung disease, right, with the traction. So here we like NSIP, okay? COP, NSIP, or UIP? Why UIP? You should know by now not to trust me.
Traction bronchiectasis.
Traction bronchiectasis. Do you see honeycombing? Yes or no?
Yes.
Where? Where?
Posterior aspects?
Yeah, so these are stacked cysts here, and also here, especially here, right? Here, so we do have honeycombing, right? So here your best choice is UIP, right? It's all the same patient. So so what's the point? There is a great deal of overlap in these idiopathic interstitial pneumonias, especially when it's associated with connective tissue disease, okay? Because these patterns can also be seen associated with connective tissue disease, right? So patients started out with an organizing pneumonia pattern, went on to an NSIP pattern, and then you can see went on to UIP pattern. So this was not idiopathic. This patient had underlying connective tissue disease. But there is an overlap in the appearance of these patterns. So this is something that you can also see in evolution. And even in patients with idiopathic disease, you can't see an evolution from organizing pneumonia to one of these others. All right, so this does occur. Now, are we done? Of course we're not done. We're talking about pulmonary fibrosis. There are other diseases, of course, that can give you pulmonary fibrosis besides the idiopathic interstitial pneumonias. So looking at the imaging here, tell me what the findings are, and then tell me what you're thinking about. Well, what are the findings? No findings? Go ahead. Well, I can't hear you. What are the findings? First of all, is this a fibrotic interstitial disease? Do we have fibrotic interstitial disease here? Yes or no? Yes. And so what are the findings that tell you there's fibrotic disease here? Yeah, right. So, if you said this was honeycombing, right, I would agree with you. Certainly there's traction bronchiectasis, right? And we have some subpleural opacities. So do you think this is IPF? So it could be IPF. Anybody else? Is there another finding that helps you here? Well, what about the pleural calcifications? Is it just pleural calcifications, or is there also pleural thickening? Yeah, there's also pleural thickening and pleural calcification. So what does that tell us? All right, so what would your number one diagnosis then be in this case? UIP secondary to what? Asbestosis. All right, so this patient has had asbestos exposure. We can tell from the pleural plaques and the pleural thickening, right? So then the fibrotic interstitial lung disease here, even though it is a UIP pattern, is going to be asbestosis, which is fibrotic lung disease secondary to exposure to asbestos. So that should be your top choice here, not one of the idiopathic, not an idiopathic interstitial pneumonia. All right. So fibrosis can be caused by other things besides idiopathic interstitial pneumonia. We can have it from environmental exposure like asbestosis, collagen vascular diseases. IPAF is an abbreviation for interstitial pneumonia with autoimmune features. So essentially, it's interstitial lung disease with features of some underlying autoimmune condition, even though they're not able to diagnose exactly what that condition is. And then we can also have drug reactions that give you pulmonary fibrosis, but you must always exclude hypersensitivity, or the clinician must always think about hypersensitivity pneumonitis if they have a patient with fibrotic lung disease. So these are other considerations when you're dealing with fibrotic lung disease besides the idiopathic interstitial pneumonias. So with asbestosis, we get inhalation of these asbestos fibers. The macrophages try to ingest them, but they die, releasing their enzymes, and that causes the fibrosis in the lung. The fibers are needle-like. They can penetrate through the lung parenchyma and get all the way to the periphery, and that's why you get reaction of the pleural surfaces also with exposure to asbestos. All right? So asbestosis, we have to think about. So we think about that, especially when we have evidence of asbestos exposure, either by history or if you have evidence of asbestos exposure when you look at the pleura. Okay? So this can give you fibrotic lung disease, tends to be lower lung in distribution. You might have clues like pleural plaques, pleural calcification, that there has been exposure to asbestos, so-called shaggy heart, that is just from the fibrosis superimposed on the cardiac silhouette. So of course, high-res CT is something that we would be doing if we're looking for asbestosis, because the earliest changes tend to occur in the dependent regions of the lung, and we don't want to confuse that with dependent atelectasis. You might choose to scan the patient's prone, okay, because that's where we see the earliest changes from asbestosis. So these are some of the findings that we would look for in a patient if we suspect asbestosis. The earliest changes this patient is scanned prone are here in the subpleural regions, these fine dot-like opacities. Those are the earliest changes that might be associated with asbestosis. Okay? Reticular opacities here, subpleural regions at the lung bases, you might see that also. And again, you can see why it would be important if you're looking for early asbestosis to scan the patient's prone so that we do not confuse this with dependent atelectasis. When it progresses, then you might have honeycombing. The subpleural peripheral honeycombing it's essentially UIP, looks just like idiopathic pulmonary fibrosis, but that's where the history of the asbestos exposure becomes important. Subpleural lines, just vocabulary. These are lines that are parallel to the subpleural surfaces, probably represents atelectasis or some fibrosis that we can also see with asbestosis. And then parenchymal bands. These are lines that are perpendicular to the pleural surface. So subpleural lines, parenchymal bands, these also might be seen with asbestosis. Okay? Pleural plaques, very important. If you see that, it tells you the patient has been exposed to asbestos. So then if there's any interstitial lung disease, then asbestosis might go to the top of our list. These can be very subtle. You can see some subtle pleural thickening and calcification here. In this case, in this patient who has honeycombing and fibrotic lung disease. Right? So this was from asbestosis. Right? The most characteristic plaques are these along the diaphragm. So these larger plaques that we can see along the diaphragmatic surface, very typical of asbestos-related pleural plaques. Don't confuse plaques with asbestosis, right? Asbestosis, the term means fibrotic disease in the lung parenchyma. The plaques just indicate exposure to asbestos. Okay, so don't confuse those two. All right, so this patient is short of breath, has some basilar interstitial opacities. Besides the big heart, is there another finding? It's a little tough on this chest radiograph, so let me show you a close-up. So besides the big heart, is there another finding?
Dilated esophagus.
Yeah, this is the dilated esophagus here over the trachea. Here's the trachea, this is a dilated esophagus. So what are we thinking about here for the patient's interstitial lung disease? Scleroderma. Right. So here's your dilated esophagus, your interstitial lung disease. Okay? So if you're given a case on exam where we have interstitial lung disease and you notice the esophagus is dilated, then scleroderma is what you're going to be thinking about there in that case. And here you can see the changes within the distal phalanges can be associated with scleroderma. Okay? This patient is short of breath. What are the findings on the chest radiograph? Well, do the lungs look normal? What's wrong with the lungs?
It's like right lower lung and peripheral bilateral increased interstitial.
Yeah, after 50 cases of interstitial lung disease, I'd assume at this point you would talk about reticular opacities in the lower lung distribution. Right? Okay, so, I mean, we've gone through a whole differential of what this could be. Now you, in your borderline clairvoyant fashion, tell me exactly what this is and why. Well, of course, the game is,
chronic eosinophilic pneumonia.
does that give you reticular opacity? What do we look for chronic eosinophilic pneumonia? We look for what?
Peripheral consolidation.
Peripheral airspace opacities for chronic eosinophilic pneumonia. So we're playing the game of what's the other finding, right? What's the other finding on the chest radiograph? What? Speak up. So the shoulders look abnormal, right? What's wrong with the shoulders?
They could have rheumatoid arthritis.
Okay, so this is interstitial lung disease in a patient with rheumatoid arthritis. You have bilateral symmetric narrowing of the shoulder joints. It's a patient with rheumatoid shoulders. Patient with rheumatoid arthritis, this is interstitial lung disease from rheumatoid arthritis. Of course, honeycombing, you can see, can look like a UIP pattern, and those are the changes in the hands, the rheumatoid changes in the hands typical of rheumatoid arthritis. So rheumatoid arthritis is an underlying collagen vascular disease that can also give you pulmonary fibrosis. So what are the diseases associated? The connective tissue diseases also associated with pulmonary fibrosis. We have scleroderma, rheumatoid arthritis, less common in some of the others. I kind of touched upon IPAF, where there is an underlying connective tissue disease. It's just not clear what it is, but that can also be associated with pulmonary fibrosis. Okay? Now, is there a way to differentiate fibrosis from connective tissue disease versus fibrosis from idiopathic pulmonary fibrosis? Well, there has been some discussion of this. So there are some signs that are more commonly associated with connective tissue disease as opposed to idiopathic pulmonary fibrosis. There's the anterior upper lobe sign, where the fibrosis tends to be in the anterior upper lobes, sparing the other parts of the upper lobes. Exuberant honeycombing, where there's extensive honeycombing, greater than 70% of the fibrotic portion of the lung. And the straight edge sign, where there's a sharp demarcation between the areas of honeycombing and the rest of the lung. All of these signs have been described to be more typical of connective tissue disease as opposed to idiopathic pulmonary fibrosis. So the anterior upper lobe sign is when we have this concentration of fibrosis here in the anterior portion of the upper lobe, more typical of connective tissue disease as opposed to IPF. Exuberant honeycombing sign, notice the extensive honeycombing here within the lower lungs. Again, more typical of connective tissue disease than idiopathic pulmonary fibrosis. And then the straight edge sign, where you can see on these coronal reconstructions that sharp demarcation between the areas of fibrotic lung disease, between the areas of fibrotic lung and the rest of the lung. Again, more typical of connective tissue disease as opposed to idiopathic pulmonary fibrosis. And of course, we always have to consider hypersensitivity pneumonitis whenever we're dealing with fibrotic lung disease. So if you have extensive air trapping, right, always think of hypersensitivity pneumonitis. Whenever you have fibrosis with extensive air trapping, this has to be in the differential diagnosis, chronic hypersensitivity pneumonitis. Okay. Now there are drugs that can also give you pulmonary fibrosis, so especially cytotoxic drugs. Nowadays, immune checkpoint inhibitors. This is something else you have to ask about if the patient is being treated with these for a cancer that might be extrathoracic. This can also give you changes within the lungs. Okay, so a lot of these are associated with diffuse alveolar damage and UIP, but with this kind of diffuse alveolar damage and UIP, it usually doesn't respond to steroids. When you have organizing pneumonia as a drug reaction, that tends to respond to steroids. So this is a patient who has an organizing pneumonia pattern from nitrofurantoin, an antibiotic. So again, this pattern tends to respond to steroids if you have an organizing pneumonia pattern as a drug reaction. This patient has more of a fibrotic NSIP pattern with ground glass and traction bronchiectasis. This was from amiodarone. So this is fibrotic lung disease as a drug reaction. So it's important to look at the history of what medications is the patient taking. This is a patient who's taking a chemotherapeutic drug for cancer. And here there's NSIP and organizing pneumonia as a reaction to the drug. So it's important to check on this history when we have abnormalities in the lung parenchyma on CT scans. And of course, sarcoid can always give you fibrotic lung disease, so especially if you have upper lung distribution of fibrosis, we always have to consider sarcoid. Sometimes, though, sarcoid can fool you. There are cases when it might give you lower lung interstitial disease, even though we don't think of that as sarcoid. The term honeycomb lung, this is just end-stage lung. Any disease that gives you extensive fibrosis in the lungs can give you honeycombing. So we can see this with all kinds of diseases that give you fibrotic change within the lung. So the list for honeycombing any disease that gives you fibrosis can wind up giving you honeycombing. So that's just end-stage fibrotic lung disease. So if we have an interstitial pattern of lower lung disease, what are the things to think about? Idiopathic pulmonary fibrosis, collagen vascular disease, asbestosis, drug reactions, sarcoid, although usually sarcoid is upper lung, but there can be cases where it might be lower lung predominant. Maybe we're not dealing with fibrosis. In that case, lymphangitic tumor, bronchiectasis, those can also on the chest radiograph look like lower lung interstitial disease. And there's a mnemonic that can be used to help you in terms of lower lung interstitial pattern. So it's not that you spit out all of these things, it's that you think of these in your differential and look for additional findings that would support or negate any of these in your differential diagnosis. Okay? So this patient has unilateral interstitial lung disease, right? What could this be? What would give you unilateral interstitial lung disease? So that's an important consideration. So is there evidence that this patient had a lung transplant? Yeah, there's a clip here on the right. So this patient had a unilateral lung transplant for underlying fibrotic lung disease. So unilateral lung transplant for pulmonary fibrosis. So now we're left with one lung with fibrotic lung disease. Now there are other things to think about also like radiation therapy, et cetera, although that usually doesn't affect the whole lung. That's more geographic in terms of its distribution. So the differential diagnosis for unilateral interstitial disease, we've talked about reperfusion pulmonary edema. We talked about the tumors, lymphangitic carcinomatosis, that can be unilateral. What are those tumors? Breast and what's the other tumor? Well, the obvious tumor is lung, right. Radiation therapy, lung transplant. That's the differential for a unilateral interstitial pattern on a chest radiograph. Okay? So for interstitial lung disease, we look at the distribution, upper versus lower lung. What does it look like on high-res CT? These ancillary findings. Pleural plaques, we think about asbestos exposure and asbestosis, dilated esophagus, lymphadenopathy, sarcoid, right. Most important thing is usually the clinical information. Always go to the chart, find out what's going on, what medications is the patient taking, what are the symptoms, what do prior studies show. Do the homework when you're approaching interstitial lung disease. Okay? All right, so that's it for today. Quiz next time. Any questions?